All right, so just some basic facts about epilepsy. I put this slide in every talk but you guys probably already know the facts about epilepsy because you're here, right? But just in case you don't know all the facts about epilepsy, just some basic information. So as you probably know, 1 in 26 Americans has epilepsy. That's more than 3.5 million people. Interestingly, 1 in 26 have a seizure. So more people have seizures than actually go on to have epilepsy, which is just kind of interesting. And over 200,000 cases are diagnosed each year. More sobering statistics, about 50,000 people die from epilepsy every year. Epilepsy is more common than multiple sclerosis, cerebral palsy, muscular dystrophy, and Parkinson's combined. Interestingly also, those diseases get much more support than epilepsy. So if you look at the funding from the NIH and from the grants and other areas of support, all of those diseases get much more, even though they impact many less patients. And then the other thing to keep in mind is after failing 2 anti-seizure medications, there's only a 10% chance a new medication will be successful. So that's something just to keep in mind as you're going through your kind of daily lives with epilepsy, or whoever it is that's impacted by epilepsy, is once you've been on 2 medications, you really should be thinking about other options. We know that 30 to 35% of patients are going to fall into this category of drug-resistant epilepsy, but there's a lot of things we can do for those patients now. This is just kind of an overview slide because we're going to be looking at EEGs of different seizure types, so it's important that we know what the different seizure types are. So this is a new classification system that the International League Against Epilepsy came out with in the last few years. So we have focal seizures. So we have seizure types, and then we have epilepsy types. So the seizure type is the type of seizure that you have. The epilepsy type combines more information than just the seizure type. So we have focal seizures. Those are seizures that start in one spot in the brain and spread. And then we have generalized seizures where your whole brain fires at once. We always have an unknown category because sometimes with the information that we have, we can't figure out if your seizures are focal or generalized. And then when you take into account other information, such as what the MRI looks like, different types of information about the patient's development, and other things that are going on, we can say what type of epilepsy you have. Because there are some people that can have generalized seizures and focal seizures together, and they have what we call mixed epilepsy. And then you can have just pure focal epilepsy or pure generalized epilepsy, and again, we have unknown. And then when we look at everything together, including if we have a genetic answer or we have an underlying etiology cause, then we can give you a syndrome name. An example of this syndrome might be something like childhood absence epilepsy, where you have a child who has seizures during a certain period, they have a certain type of seizures, such as absence seizures, we have a specific EEG finding, we have a normal MRI, and if we can give you a syndrome name, then we know that those patients are going to outgrow their seizures over time. So if we can take all that information together, we can help guide our patients into what might happen in the future. And then on the the right-hand side of your screen, we have different etiologies. So you can have a structural abnormality in your brain, you can have a genetic cause, you can have had an infection, you can have a metabolic or an abnormality in the chemicals in your body, you can have an immune problem, or again, we always have unknown because sometimes we don't figure it out. And then we don't want to forget what's on the left-hand side of the screen, which is the comorbidities. So there's a lot of things that travel along with epilepsy. The most common things we see are in kids, we see developmental problems or learning problems. We can also see behavior problems. In adults, we have a lot of trouble with depression and anxiety and still ongoing learning problems. So we don't want to forget about those kind of diseases that travel along with epilepsy. We want to make sure we're thinking about those and treating those. Okay, let's look at EEG. So EEG, so probably anybody, hopefully, we'd like to think that hopefully anybody who has epilepsy or is concerned about having epilepsy or thinks they have epilepsy has had an EEG. That should be the first test that you get. So basically what we do in an EEG, the brain cells make electrical activity and the EEG is monitoring that electrical activity and giving us information about what type of seizures a person has, where those seizures may be coming from in the brain. And this is really important information because it helps us decide what to do with treatment. So you say, well, why does it matter? Well, it matters because there are certain medications that we have that treat certain seizure types. So we talked about having focal seizures and generalized seizures. There's a group of medications that only treat focal seizures. And if you give those medications to somebody with generalized seizures, you're actually going to make them worse instead of better. So that's a big problem, right? Because if we don't know what type of seizures you have and we give you the wrong medication, you're not going to respond the way we want you to. If you have generalized seizures and you get a focal medication, that's not good. And it's the same vice versa. So if you have focal seizures and you get a generalized medication, that's not going to work for you. So it's really important that we try to sort this out. The EEG can be very helpful. So it's also helpful when you think about it, you think, well, did we record a seizure during our EEG? Probably not. Most patients have never had a seizure recorded on EEG, but an EEG can still be very helpful because you can have abnormalities on your EEG when you're not having a seizure that can help the doctor know what type of seizures you're having. Now, in a perfect world, I did a talk earlier on genetics, and I mentioned my perfect world. Not very many people live in my perfect world with me. I'd like more people to come join me in my perfect world, but not everybody's there yet. I'd really like the insurance companies to come join me in my perfect world, but they haven't come around yet. In my perfect world, everybody would have an EEG and their seizures would be recorded. Because if I see your seizure, then I know exactly what's going on. Most of the time. Sometimes the electrical activity is a little stubborn and it stays deep in your brain and it doesn't quite make it to the surface, and so I still don't know what's going on. But most of the time, having a seizure recorded gives me a lot of information. So who should absolutely have an EEG that records a seizure? Anybody who's in that drug-resistant category. So if you happen to be a person who's failed more than 2 treatments, then you absolutely need to tell your doctor you want to have an EEG that records your seizures. Even if that means that you have to go into the hospital and stay there for a couple of days and have your medications tapered to induce a seizure, that's when you definitely need your seizures recorded. Why? Because you have to make sure you have the right diagnosis. Maybe your doctor has been treating you for generalized seizures and you really have focal, or your doctor's been treating you for focal seizures and you really have generalized. Even the best doctors make mistakes based on the story, because based on what you're saying and what maybe the videos on your phone show, we may think for sure your seizures are focal and we're treating you with focal medications, and we do an EEG and we find out they're generalized. It happens all the time. None of us are perfect. We all make mistakes when we're looking at the videos and we're hearing the stories. So you definitely want to have your seizures recorded if you have drug-resistant epilepsy. If you're in a newly diagnosed category and you've just had new onset seizures, a routine EEG, 40, 60-minute EEG is a fine place to start. But if your seizures continue and the treatments aren't working, then you really want to have seizures recorded. So what we do is we put these little electrodes, EEG electrodes, on your head, and we put them in this order. So what you'll notice is that the left-sided electrodes are numbered with odd numbers. So everyone remembers basic math. We have odd numbers and even numbers. You have to go all the way back to grade school. Odd numbers and even numbers. The odd numbers are on the left, the even numbers are on the right. Now they're kind of numbered, they're kind of lettered after where they are in the brain. So FP stands for frontopolar, so that's on your forehead. F stands for frontal, so you see the frontal electrode. I love having a pointer. So here's frontopolar. Those actually sit on your forehead. This is supposed to be your nose, and these are your ears. This is kind of looking down on the head, right? It's a graphic, so it's the best we can do because I don't have a 3D model. Although I could bring one next year. That would be kind of fun. Or we could have a tech come in and put electrodes on somebody here live in action. Right? I got a whole bunch of techs out there. That's what I should have done. Maybe that would be even more fun. Okay, so we have F7, which is actually the anterior temporal lobe. So let's go back one more step. I may be jumping ahead. You have 4 lobes in your brain. You have the frontal lobe in the front. That's easy. You have the parietal lobe, which is on the side. You have the temporal lobe sits down by your ear, and you have the occipital lobe in the back. So we have F3 is frontal, F4 is right frontal, F7 and F8 is really the front of the temporal lobe. T3 is temporal lobe, T5 is the back of the temporal lobe, O1 and O2 is occipital lobe. Then you've got the parietal lobe here at P3. C3 sits right over the motor strip, that's central. And then you've got the Z's are the ones that go right down the top of the head. They're right here in the midline. So those are the electrodes. Now what we do when we read an EEG is we actually connect the electrodes together and we look at the electrical activity. So those little dashes are kind of show how the electrodes can be connected. We can connect those electrodes any way we want. And what we'll do is we compare the electrical activity between 2 electrodes and try to decide if it's an abnormal wave or a normal wave. And the typical way we do this is like this. So typically when we put those electrodes on your head, the way we look at that EEG on the screen is by comparing 2 electrodes. Typically we compare FP1 to F7, then F7 to T3, T3 to T5, T5 to O2. And that makes a row of 4. And we look at that row of 4. Then we do the same thing on the right, and we put that row of 4 next. And then we go to the next row here, FP2 to FP1 to F3 to C3, P3 to O1. We put that row next, and then we put the same thing here. And then we put the middle ones. Now if you look at that, those kind of look like 2 bananas. It helps that I did it in yellow. So we call that picture on the page, we call it a double banana montage. Montage is the word we use for how the electrodes are arranged on the page. So most EEGs are in that configuration. So when your doctor shows you, and if I show my patients EEGs all the time. I love showing patients EEGs because I think it's easier to look at the picture than try to describe it with words. Most of the time when they show you that page, it's going to be in this configuration. You're going to have the ones kind of on the outside that go over the temporal lobe, and then the ones on the inside, and then the right and then the left. Now different doctors do it different ways. Some do left, left, right, right. Some do left, right, left, right. Some do outside, inside, then inside, outside, but it doesn't really matter. It'll be some configuration of left, right, left, right. And it'll be most often this double banana kind of picture. So what do we look at when we look at your brainwaves? The first thing we're looking for is to make sure you have normal brainwaves. So despite what people tell you about how normal or abnormal you are, most people have pretty normal brainwaves. So when you open your eyes, you should have brainwaves that look a certain way, and when you close your eyes, your brainwaves change. That's why when you have an EEG, the texts have you close your eyes. So there's a very specific rhythm we see in the back of the brain, in the occipital lobe, when you close your eyes. And it actually starts off slow, and it speeds up as you get older. By the time you're a certain age, it should be a certain speed. If it's not, that's an abnormality. So as an epileptologist, I look at an EEG and I'm watching for the text to have you close your eyes, and I'm looking for that background rhythm of your brain to be a certain frequency or a certain speed by a certain age. And if it doesn't get there, then I'm going to have to read that EEG as abnormal. So that's what we're looking for. We're also looking for normalities when you go to sleep. When everyone goes to sleep, they make certain brain waves. And then I'm looking for abnormal waves. So first I want to make sure your waves are normal when you're awake and sleep, and then I want to look for abnormal waves. So we have abnormal waves that we see in patients who have seizures. We typically call these spikes, which are pointy waves that look like if you sat on them it would hurt. Those are highly epileptic and often seen in patients with seizures. We have sharp waves that are not quite so spiky. They're a little more rounded, would maybe be a little more comfortable to sit on. And then we can have a combination of waves. And these can be focal or they can be generalized, just like you can have focal or generalized seizures. All right, let's look at some pictures. So this first picture is a spike. You can see how pointy it is. Definitely if you sat on that, it would not be comfortable. This is a spike followed by an aftergoing slow wave. We see this in patients with seizures. This one is a little more rounded, not quite so spiky. This is a sharp wave followed by a slow wave. And then this is just a slow wave. So when do we see slow waves? We see slow waves when there's something wrong with the brain underneath. So we could see this in somebody who has a tumor. If there's a brain tumor taking up space and there's not brain cells, you're going to see a slow wave. That can tell us that someone needs to get an MRI because there's something abnormal there. If you've had surgery and there's an area in the brain where brain's been removed or treated with laser ablation, your brain may be slow. If you've just had a seizure and your brain is a little sleepy because it's recovering from a seizure, your brain waves may be slow. Sometimes the brain waves are slow in kids who have developmental disabilities because it doesn't work as well as other patients do. We can see slow brain waves. So there's a lot of reasons that brain waves can be slow. If you just got a big dose of a sedating medication, your brain waves can be slow. Slow brain waves you can kind of correlate with being sleepy. So if you're sleepy on the outside, your brain waves may be slow. When patients have brain infections, their brain waves get slow. So slow waves are very nonspecific. As a person reading the EEG, all I can say is the brain is slow, and these are things that might cause that. The person who had ordered the EEG has to then look at the patient and try to figure out why the brain waves are slow. If they're slow just in one spot, that would be concerning for something focal in the MRI. If the whole brain waves are slow, that would be something more global. All right, so let's look at some more pictures. So these are, again, sharp waves. These are a little bit less epileptic than these spikes. So these look a little more angry, a little meaner. They're really pointy and kind of ugly looking. These are a little bit more benign looking, more rounded. Here are what we call polyspikes. So these are spikes that have gone back to back. So you have up and down, up and down, up and down. So we see these in epilepsy as well. And sometimes we have the polyspikes followed by an aftergoing slow wave. So these are all seen in patients with epilepsy. We're going to look at some examples, don't worry. Now what we do when we're looking for focal discharges, because of the way the EEG is read, is we're looking for what's called a phase reversal. So there's a convention in reading EEG that when a wave is going up on the EEG, it's what's called a negative wave. And negative waves are epileptic. So if we look at this EEG, when these points go together, so we have F7, T3, T3, T5. When you have this wave pointing together, that means there's a negative wave at the shared electrode, which is T3. So this means that there's a spike coming from T3 because the points are pointing toward each other. When the points go away from each other like this is a positive wave. Negative waves are epileptic, positive waves usually aren't. So when we look at our EEG, we're going to be looking for times where the points go toward each other. That tells me that's an epileptic or a spike coming from that shared electrode. So that's what we're going to be looking for when we look at our EEGs. So this is a nice normal EEG. So again, we have our groups of 4. So this is F7 to T3 to T5 to O1. So this is a group of 4 coming from the left. When we think back to our double banana, this is that outside rim. This is the same thing on the right. And then this is the inside rim. This is the other side of the banana. And then this is the same thing on the right. So if you look at these brain waves, you'll notice in the front here, the brain waves are short and they're very fast. As we go from front to back, the brain waves get taller and slower. So if we look at this page, each of these green lines is 1 second. And you see the brain waves, if you look at the brain waves between this second, the brain waves in the front are shorter and they're much faster. The line is much faster, more squiggles in that second. And as we go from this line to this line to this line to this line, the brain waves get slower, there's less waves, and they're taller. Everyone can appreciate that? So we call that the anterior-posterior gradient. From the front to the back, the brain waves get taller and slower. This pattern right here, this nice, pretty sinusoidal rhythm, this is called the posterior dominant rhythm. This is the rhythm you see when the patient closes their eyes. So the eyes are open at the beginning of the page, they close their eyes, and you get this nice, pretty rhythm. What we do is we actually count this. We see how many points there are in a second, and we see if it's normal for the patient's age. This EEG looks nice and normal. Toward the end of the screen, the patients open their eyes and it's gone away. Everybody has that. So that's the posterior dominant rhythm. I've pointed out there with the purple arrow. All right, now we do other things when patients get an EEG. We flash lights. We do things to kind of irritate the patients mildly. We flash lights and we make them breathe deep. So why do we do those things? There are a lot of epilepsies that are what we call photic sensitive, where patients have seizures from flashing lights. We can tell who's likely to do that by flashing lights while they have their EEG. If it brings out an abnormal pattern on the EEG, then we can tell those patients to try to avoid flashing lights. Most patients are sensitive to certain frequencies and to certain colors. Now, unfortunately, in the EEG lab, we use only one color, so we can't help with the different colors, but we can tell you which frequency is most likely to cause your seizures. We do a lot of different frequencies. As you notice in the lab, we start with slow, and then we go to very fast. You can see the lights are flashing by this red line at the bottom of the page. That's the frequency that we're flashing at. Now, our brains have the normal tendency to accommodate to what it sees on the outside world. So you can see here in the back of the brain, this posterior dominant rhythm that was normally slow, about 8 to 10, it's sped up and now it's syncing with the flashing light. So that's just something your brain does normally because it accommodates to its outside world. So this is a normal, what we call photic driving, where the brain is syncing with the flashing light. This is a normal thing that we see. It's not good or bad, it's just something that our brain does. It's actually kind of cool that your brain can do that. If we speed that light up, that tendency to, that pattern in the brain is going to speed up as well. And if we slow the flash down, then this frequency is going to slow down. So that's the frequency speeding up to match the flashing light, which is completely normal. This is another picture of it. This is a little faster. You see it sped up, it got faster. Totally cool, right? I mean, I'm kind of an EEG geek, but it's totally cool. All right, maybe not so cool, but I think it's cool. All right, there's some more photic driving. I mean, we could look at this stuff all day. All right, let's look at hyperventilation. So why do we do hyperventilation? Brings out seizures, right? So if I have a child in clinic that I think is having seizures that are induced by hyperventilation, I hyperventilate them in clinic. So absence seizures are likely to be induced by hyperventilation. There's a lot of seizure types that we can induce in hyperventilation. So we have the kids breathe deep for usually 2 to 3 minutes. But what else happens? Has anyone done the hyperventilation in an EEG or done it with their child when we're hyperventilating their child? What does it make you feel like? How do you feel when you're hyperventilating? Or if you've gone out and run and hyperventilated? Lightheaded, right? So what do you think your brainwaves are going to look like when you're lightheaded? Slower. Very good, right? So this is so easy. Like I've trained for 2 years to learn this, and you're learning it in 20 minutes. You all can put me out of work and I'll go retire. So your brainwaves get slow because you're increasing the CO2 and it makes your brainwaves slow. So here's the slowing, right? You can see it here, right? All these big slow waves. You see how they're overtaking the EEG? And the EEG just looks slow. It has that appearance of being slow. So all this slowing is what we see in hyperventilation. This only lasts for a couple of minutes and then it goes away. So it's completely normal when you're hyperventilating to have your EEG get slow, as long as it's not focal and it goes away. So that's completely normal. Now we like when the techs tell us that they're hyperventilating, so when we see this we don't think, I wonder what's going on with that patient. Why is their EEG suddenly slow? But all the techs are good and they mark that and we know that's what it is. So there we pointed it out for you, the slowing from hyperventilation. So here's another patient with hyperventilation. This patient has a lot of slowing. Look at that really prominent slowing. You think, oh my gosh, what's wrong? But it's just hyperventilation, completely normal. There's another picture, the hyperventilation. All right, so here's another. This is something that's happened different. So this looks different than the first EEG, right? We wonder what this is. So we have some kind of spiky waves, right? You see these boys with points. You think, oh gosh, those look like spikes, right? This is sleep. This is normal sleep. So why is that normal sleep? Because we have something called vertex waves. So we have spikes in the middle of the head during sleep that are very spiky. These are most prominent in children. So this is the difference between a pediatric epileptologist and an adult epileptologist. We're very used to seeing this in children. Sometimes when an adult epileptologist reads a young child, they'll be like, oh my gosh, look at all those spikes, and they'll send them to me to see them, and I'll look at the EEG, I'm like, oh, that's just vertex. You forget that children do this, adults don't. So you see a lot of these very active vertex spikes in children. It's completely normal. Adults have these, but they don't have them this frequent. So sometimes they confuse some adult readers who don't read a lot of kids. Most adult readers are very good, but every now and then we'll get one of these that they come to send to us. All right, so now let's look at this EEG. What do we think about this EEG? Did anything look funny on this EEG?
Some
Yeah, so this is muscle. This really fast stuff is muscle. So if we put electrodes here on the side of our heads, and if you bite down your teeth, it activates your muscles in the side of your jaw, and that makes that fast activity. So let's think about the brain is symmetric, right? So your left side and your right side should look the same. So this is left, this is right. Do these look the same? No. So these lines are flat, and these lines have activity. So the question is, which side is abnormal? Is the side abnormal with the activity, or is the side abnormal that's flat? So it's the flat side that's abnormal. Yeah, so this is a patient who actually had a hemispherectomy. So this patient had epilepsy surgery because of a very abnormal brain. This is an older patient who had an old-fashioned epilepsy surgery because the newer one where you just disconnect didn't work and actually had the whole brain removed. So there's no brain here to record, so the lines are flat. So this is just to show that there's asymmetry. So what we like to do when we look at EEGs is compare the two sides, because they should be the same. So anytime you see an abnormality, that's good. You figured out that there's something abnormal, but then the question is, what's the abnormality? Which side is abnormal? So it's important to notice this. This is all muscle activity. This really spiky stuff is usually not brain, and this is all muscle. So that is something we haven't seen yet, but that's a normal muscle artifact. It's very hard to read EEG through muscle. This is why we try to get our patients to relax when they're having their EEG. If they're squinting their eyes or doing a lot of talking or chewing is the worst. When we have patients in our monitoring unit and they're eating, it's almost impossible to read their EEG because all the jaw artifact. It makes the muscle activity just completely get rid of most of the brain activity. So we have to be very, very difficult to read those. Okay, so here we have another abnormality. If we look at all of these big waves here, this is slowing, and it's focal. We see it predominantly here in one spot. So that would be concerning, that there might be a brain tumor or someone had a prior injury in this spot, because it's predominantly here in the right temporal region. So that stands out as an abnormality, focal, and it's very slow. So that's something that we'd want to be cognizant of and maybe get an MRI on that patient. Okay, here we have a lot of abnormal epileptic activity. So these are spikes, these are sharp pointy waves. They're coming from the right side. I can't read the waves. That's the right central area. So this would be an indication that this person has a focal area of irritability that's likely to cause seizures. So this is what we call an interictal abnormality. So the words we use in epilepsy, ictal is the word we use for seizure. Interictal is the word we use for in-between seizures. So if you have interictal, what we call epileptiform abnormalities, epileptiform means it's possible of causing seizures. That doesn't mean you're having a seizure. That means you're capable of having seizures. So we describe it as irritability in the brain that's possible of causing seizures. So you can have a very active interictal EEG with lots of spikes and never have a seizure. You can have no spikes on your EEG and have seizures. Right, so 50% of people with epilepsy have a normal routine EEG. So it's not 100% match. So just because you have a normal EEG doesn't mean that doesn't rule out that you have epilepsy. So we have to be very cognizant of that. We've had patients where they've had a routine EEG, they're told it's normal, and they stop taking their medicine because someone thinks they don't have epilepsy anymore. Don't do that, that's not what happens. So that's when you want to get a longer EEG. If you think about it, that if you have someone who gets a 24-hour EEG, I can find almost in every 24-hour EEG a 30-minute spot where there's nothing abnormal. If that was the 30 minutes you had a routine EEG, it would have been normal. Yet if I do a 24-hour EEG, I'm more likely to find something abnormal. So if you've had a routine EEG that's normal, you probably need a longer 24-hour, 48-hour study to find the abnormalities. Much higher yield of finding something abnormal. So these focal spikes tell me that this person has a higher likelihood of having seizures than someone who doesn't have focal spikes. But even having these focal abnormalities doesn't guarantee they're going to have seizures. We find that a lot of families where there's a patient with epilepsy, other family members have abnormalities on their EEG yet never have seizures. So some of these abnormalities can be genetic. Okay, these are some more focal spikes. These are on the left. So this last page, the focal spikes are on the right, and these spikes are on the left. One side's really not better or worse. They're just different sides of the brain. The problem comes if you get to the point where you might need surgery. In most patients, the left side has more what we call eloquent cortex, so more functional brain. Most of us have our language areas on the left side of the brain. So that makes surgery considerations slightly more difficult. Doesn't mean we can't do it. It just makes it slightly more difficult because that's the area where most people's language lives. So we have to be mindful of that if we're working someone up for surgery. Now this page looks really busy, right? You look at that patient and think, wow, that person must have really bad epilepsy because look at all those spikes. They're everywhere. Actually not. This is one of the most benign conditions we treat. So there's lots of spikes. You see them left, right, and this patient's asleep and they got activated. So this is what we call sleep activation. So when this patient fell asleep, their spikes went all over the place. This patient has a condition we call self-limited focal epilepsy of childhood. This is a type of epilepsy that's outgrown in almost every patient who has it, but they have very active EEGs, and that's classic, that's part of the syndrome. They have pretty benign epilepsy where their seizures are fairly rare. They usually have seizures when they're falling asleep, usually focal motor, but almost all these patients outgrow their seizures. So it's not a one-to-one. You don't necessarily have a bad EEG and have bad epilepsy, and you don't necessarily have a good EEG and have good epilepsy. So they don't fit 100%, so we can't always rely on that. I often get patients with this EEG referred to me from outside doctors or adult doctors who think this is a really bad problem because EEG looks so bad, but actually this is a pretty easy to treat problem. But it looks bad. You have to agree. There's lots of these little spikes from everywhere, but not such a bad problem. Okay, now this is something we haven't seen yet. So what looks different about this EEG from all those ones we just looked at? And so this is, those other ones had just one focus, and this is the whole page. Right, so this is generalized. So this is a generalized epileptiform discharge, whereas these, come on, so these are focal, just one place. So this was focal left. This computer is very slow. This is focal right. And then if we look at, that was focal everywhere. And if we look at this one, you see how the whole page changes? We call that generalized, right? So that's a generalized spike and wave. So if you look closely, there's spikes, which are the pointy waves, and then there's a slow wave, which is the aftergoing slow wave. So we call that generalized spike and slow wave. So the type of seizures patients have who have this discharge are usually the myoclonic seizures, which are the jerk seizures. They can have staring seizures, just staring blankly. They can also have bigger seizures, generalized tonic-clonic seizures, or generalized clonic, or generalized tonic. The other patients, the focal seizures, they can have just about anything if you have a focal EEG. So it's very easy on EEGs. You can have a patient present with staring. Let's say the patient just, all the parent says is, they just stare, they just zone out. That can be a focal seizure or a generalized seizure. You can see how easy it is for me to tell on EEG which it is. This looks completely different than the focal discharge, and we treat those seizures completely different. So that's how an EEG can be so helpful in telling me what's going on. Even without recording a seizure, just a short EEG, if I see this discharge, I know for sure that patient's having generalized seizures and not focal. I know exactly which pathway of medication to choose. This is another generalized spike and slow wave discharge. Again, helping me determine that someone's going to have generalized seizures. And this one is another generalized spike and slow wave. So this one was associated with the myoclonic jerk. So this patient actually had a twitching seizure when this discharge happened. This one's much faster. The spikes are close together. So the spikes come back to back to back. So this person actually had a clinical seizure with this discharge, with the little kind of body twitch. All right, we already looked at that one. Okay, well, I'm going to show it again. So this is that same disorder we talked about. Whoops, wrong direction. Oh, too many buttons on the computer. Okay, so this is a patient with this, what we call self-limited focal epilepsy. These are kids who have these seizures at nighttime where they have focal seizures, and the seizures usually go away with time. We have these focal discharges. These are coming from the left side. We have some on the left side here. We have some on the right side. So the hallmark of this disorder is you have discharges coming from both sides of your brain, which is fairly unusual because most patients either have left-sided seizures or right-sided seizures. It's fairly rare to have both-sided seizures. And then when they have a seizure, this is what a seizure looks like. So a seizure is usually rhythmic, continuous activity. It usually evolves over time. So it usually starts slow and then speeds up, or it starts fast and then slows down. So you can see here we have this very nice rhythmic discharge starting right here in the motor area, because these patients have motor seizures, and over time the discharge gets taller and it gets a little faster. This patient had twitching of the right side of their face because the seizure is coming from the left side of their brain. So this is a type of epilepsy that goes away with time. Now this is a slightly different type of epilepsy. Here we have the discharges in the back of the brain. So we have these nice little rhythmic spikes here in the back of the brain. This is the in-between seizure EEG. So this is what we call self-limited occipital epilepsy. So these patients have discharges coming from the back of the brain, and they have very interesting seizures. The young children tend to have vomiting and then motor seizures. The older children have a lot of visual stuff. They have any kind of visual stigmata, often flashing lights, and they're often misdiagnosed as having migraines because they see flashing lights and then they get headaches, and often they're told that they have migraines. And all you need is a routine EEG to figure out that they don't. Now this is what an absent seizure looks like. So kids who have staring seizures where they just zone out for a few seconds, sometimes their eyes flutter, and then they're back very quickly, 4 to 6 seconds. This is what the EEG looks like. This is a very clear EEG. So I have a lot of kids who are diagnosed with ADHD, or the teachers say they're just inattentive, they're just misbehaving, and then we get an EEG and we find they're having 5 or 6 of these an hour. These are not kids that are misbehaving, they're not paying attention, they don't have ADHD, they have seizures. It's very easy. This is a generalized seizure. You see the whole page changes. Most of these kids have what we call 3 Hertz spike and slow waves, which means there's 3 of these spikes per second. If you go in and count between these tall black lines, you actually count 3 spikes per second. Sometimes their eyes flutter in rhythm with that spike and wave. So you see an eye flutter 3 times per second, exactly in sync with those spikes. If you watch the video, as the EEG is playing, the eyes flutter exactly with each of those spikes. Yeah?
So how long is that in time?
So each of these is 1 second. Each of this is 1 second. So this one's 1, 2, 3, 4, 5, 6. That's 6 seconds. And they can be as short as 3 seconds. Usually it has to be about 3 seconds long to be a clinical seizure. But I've seen some go 20, 30 seconds. Yeah. But it's a very abrupt onset and offset. So some of these kids will be talking, they'll have their seizure, and they'll pick up their sentence on the back end of the seizure. That's how quick they can be. Sometimes they get a little confused afterwards, but there's some that are so brief that they finish what they're saying at the end of the seizure. With this is a generalized seizure. It's interesting because you can have a generalized seizure like this, absence, that it causes staring, but you can also have a focal seizure that causes staring. The focal seizures tend to be a little slower on, so the kids go into it a little more slowly, and they're a little slower to come out of it. They come out of it a little confused, and they're not sure what's going on, and it's a little harder for them to get back. The absence seizures, it's almost like someone flipped a light switch. They're there, and then they're gone, and then they're right back. That's sometimes how we can tell which one it is, although the EEG is the easiest way to tell which one, whether it's focal or generalized. So why does it matter? Because we treat them completely different. The drugs to treat absence seizures are completely different than treating focal staring seizures. Okay, this is, they get a myoclonic seizure. So this is a patient that has, the myoclonic seizures are quick jerks of your body. It's not a real common seizure type. A lot of people don't know about it, so they don't ask patients that they're having them, and then a lot of them go missed. So this is the interictal discharge, and this is the ictal. So ictal is seizure. So this is just a burst the patient has without a seizure, but this one actually caused a seizure. And during this, there was actually a twitch of the upper body. And this is about 1.5 seconds. This is a little less than a second. This is about 1.5 seconds. Again, whole page changes, very spiky, very short seizures, but they're absolutely seizures. So you can see here there was a patient event button pushed because the parent saw the patient have a seizure during that event. Okay, these are drop seizures. So drop seizures are another seizure type. This is a type where the patient either has a head drop or sometimes they fall completely to the ground. So this can also cause sometimes an atonic seizure. So it's similar to the myoclonic seizure, but looks slightly different. So again, it's a generalized pattern. You see the whole page change at once, and there's a little bit, the discharge goes up first, and then there's this big downward with a little bit of a fast squiggle with it. So these patients have this loss of tone where they kind of fall to the ground. And they tend to come in clusters where they're back to back to back. So you can see there's one here, then there's a few seconds of no seizures and another one, which is pretty classic. Yeah.
Is this where you'll see them turn their head to one side too?
Sorry.
Is this where you'll see them turn their head to one side?
They can sometimes.
Okay.
Yeah. Sorry, I have one bad ear. I have to move a little closer. No worries. Okay, now this is a tonic seizure. So tonic is the word we use for stiffening. So tonic seizures have a classic EEG pattern. They all look exactly the same. So we get this, what we call in the EEG word low amplitude fast. So low amplitude means short and fast is fast, just squish fast waves. So you see the page gets very flat and you have this very fast squibble. So you're going to say, gosh, that looks just like the muscle artifact that I showed earlier. And it does look like the muscle artifact, but it's slightly different. So this is actually brain, not muscle. And there's some muscle mixed in because the patient gets really stiff, but it's a combination. But this is definitely coming from the brain. It's definitely a tonic seizure. So the brain, the whole EEG flattens, the waves get really short, and it's like someone scribbled on the page. Classic tonic seizure. They all look the same. When we see this, when we're reading EEGs and we see this pattern, we know when we turn on the video the patient's going to get stiff. It just always happens. So this is very clear to us. Tonic seizures are fairly unusual to only have tonic. Now you can have what's called a generalized tonic-clonic, where you get stiff first and then jerk. That's common. But to only have a tonic seizure, it's a little bit of an unusual seizure type, usually seen in patients with developmental disabilities and specific genetic disorders. But we do definitely see them. So this is the EEG for a tonic seizure. The EEG can be very helpful because we can know very clearly. So this is generalized tonic-clonic. So you see we start with these generalized spikes. This patient actually had clonic, tonic, clonic. So this is the clonic portion here. Then when it gets flat with these low amplitude spikes, this is where the tonic portion was. And then there was more clonic. I don't have the next page. So again, it generalized. Generalized, generalized, generalized. So this is the generalized rhythmic jerking. The patient jerks in time with each of these discharges, and then the tonic portion was at the end. Okay, now this is a specific syndrome that we only see in children. This is what's called infantile spasms. I don't know if anyone has a family member or relative with infantile spasms. This is the non-seizure EEG. So interesting about seizures is most patients who have seizures, their in-between seizure EEG looks pretty good. And it doesn't give us a lot of information. We're looking for those abnormalities. In infantile spasms, their EEG when they're not having seizures is very abnormal. It looks like this. So if you looked at this, when you remember the very first page I showed you of that normal EEG, how nice it looked, it was all organized. The brainwaves were low in the front and they were higher toward the back, and it just looked very nice and organized. This looks chaotic. It looks disorganized. It would look the same upside down and right side up. So we call this hypsarrhythmia. It's a very easy pattern for epilepsy doctors to recognize because it just looks chaotic. When we train our trainees, we tell them anything that looks disorganized and chaotic and would look the same upside down and right side up, that's probably hypsarrhythmia. You don't want to miss this. We consider this a neurologic emergency. So this is something that you want to treat right away. The longer your brain goes with this pattern, your brain's not learning when it has this pattern. So we really want to treat these seizures right away. Now, interestingly, this is where the spasm occurs. This actually looks more normal than this does. So the EEG pseudo-normalizes during a spasm. And what we see is a flattening of the EEG, and we see some fast activity, like this little burst of fast activity. Fast is when the lines are pushed together. So that's almost looks a little more normal, but it's actually the abnormality. Now when kids have spasm, they have either a crunching or they have an arching. This usually occurs in babies 6 to 9 months, and they cluster. But this is a very bad type of epilepsy that we really want to be aggressive in treating. And it's easy to diagnose, so most times we have to actually capture the seizure so we know what's going on. With this, as soon as you turn the EEG on, it's so abnormal that you don't even always need to capture the seizure because we can tell just by the background EEG because it's so abnormal. All right, so this is another epilepsy syndrome that we see in children called Lennox-Gastaut, which is a difficult type of epilepsy where kids have a combination of bad epilepsy, developmental disabilities. They often have drop seizures and tonic seizures. And you see it's also a very chaotic, disorganized EEG, although a little more organized than the last EEG. And we see this very clear pattern here in the front of the brain, or the top of each 4 lines, where they have this very prominent spike and then this long slow wave, this kind of bifrontal slow spike and wave. The big slow wave and then a spike, big slow wave and then a spike. So this is classic Lennox-Gastaut. This is also a very difficult to treat epilepsy and a pattern that we look for in kids with bad seizures. And again, this is something that's done that we see when they're not seizing. So it's something that we can find when they're not seizing. This is another difficult EEG pattern. This is what's called burst suppression. We see this in some babies with rare genetic diseases where the EEG is just flat, with a little burst. So this is not a pattern that we want to see because it's something that's fairly difficult to treat. And then another very interesting pattern is what we call electrical status epilepticus asleep. This is something that's become a little more popular here recently. This is associated with an interesting disorder called Landau-Kleffner syndrome. The other word for this is epileptic aphasia. So there's a lot of kids that are misdiagnosed with autism who actually have this disease. So these kids present normally developing until around 4 or 5, and then they start having seizures, which are usually easily controlled, and then they lose their language. And when they lose their language, they get like an expressive aphasia, which means they're not able to talk, but they still have some understanding of language. And when we do their EEG, they have a completely normal awake EEG. It just looks beautiful. And then when they start to go to sleep, they start getting a few spikes. But when they get into slow wave sleep, so we have different stages of sleep. We have initial sleep, we have drowsiness, then we go into deeper sleep and we have slow wave sleep, which is our deep sleep, and then we have REM, which is the deeper sleep. In slow wave sleep, their sleep looks like this. Now this doesn't look anything like sleep. This looks like they're in status. This looks like an EEG tracing of someone having what we call status epilepticus, which is a continuous seizure. But these children aren't doing anything. They're just laying there sleeping, as peaceful as possible. The problem is if you do a routine EEG on these patients, you will not see this because it only happens in slow wave sleep. And I tell you, in an EEG lab, as soon as you go into drowsiness and early sleep, they wake the patients up and send them home because they got some drowsiness and early sleep. Completely okay, that's what EEG labs do. But this only happens in slow wave sleep. We do not record slow wave sleep in an outpatient lab. So in order to find this pattern, you have to get an overnight EEG. And so this is missed in a lot of patients. And so because they have these expressive language problems, they're often given the diagnosis of autism, which is not what they have. They have an epileptic syndrome. The problem with this is this can be treated. We can actually treat this EEG pattern, normalize it, and the language comes back. So it ends up looking like a treatable form of autism, which of course it's not. It's an epileptic syndrome that was misdiagnosed. We can treat this, in some patients we can treat this with 1 dose of Valium. We give them one high dose of Valium, and their EEG normalizes within about 15 minutes, and they start talking the next day. And it can be that miraculous. So really, anybody who has this story of normal development and then loss of language needs an overnight EEG. Because you don't want to have, you don't want to miss one case of this. Like, I'd rather do 100 EEGs than miss one case of this. And this is such an easy, this is not something you miss. This is not like a subtle pattern that you need some expert EEGer to read. This is something that anybody would pick up on. So this is something, but this is a disease that most pediatricians have never heard of. So this is something that we really need to educate and really get the word out. This is why there's a lot of families that have organized in the autism community about getting overnight EEGs so that we're not missing this diagnosis. So luckily our family communities are a little more organized than our medical community to make sure that this is well understood and known so that we cannot miss it. Because you hate to miss something you can treat. That would be really tragic. All right, then this is just some seizures. So this is a seizure. A seizure is usually anything rhythmic. Seizures are not always spikes. If the seizure is coming from deep in the brain, our electrodes are on the outside of the brain. By the time the seizure gets from deep in the brain to the outside of the brain, sometimes the spikes are now slowing because they're so deep in the brain. So if it's rhythmic, it can be a seizure. So this is the temporal lobe up here, but we have a lot of muscle, so it's hard to see underneath here. But we see it reflected here in the parasagittal or the side of the brain as well. So this rhythmic activity is the seizure. This is a patient having a right temporal seizure. This is a little bit. Gosh, my EEG is so slow. Okay, this is a little bit better. This is a left temporal seizure. So here's a little bit easier to see. You see these rhythmic spikes. This electrode is sitting right over the temporal lobe, and you see this very nice, sharply contoured activity. The rhythmicity is what we're looking for in the seizures. It starts out slow, and then it builds taller and faster. That's the hallmark of the seizure. And you can see that it's just focal. It's just in one spot. So both of those patients had surgery, and they're both seizure-free. Okay, this is another seizure. You can see that this seizure is starting out here on the left side. You see a little bit here on the left side. This is the first page. And then as we go, come on, you can do it. Turn the page. There we go. And then you see on this page it's gotten faster. See how much faster the waves are? And it's spread a little, but it's still just there in the left back. And then this is the third page. Now it's gotten really fast. So that's what seizures do. They tend to speed up. They tend to get taller and faster as they go. Okay, this is another seizure starting here in the back, this rhythmic activity. And then you see here it's spread. So now it's spread over the whole hemisphere. This whole hemisphere has this rhythmic, sharply contoured activity. But it's up here, it looks completely fine. This is why we put so many electrodes on. If you only had a few electrodes on in the spot the seizure wasn't coming from, you never would see it. Here, the whole hemisphere now is seizing. All right. Okay, I'm going to show you one picture from a surgical patient. This is a patient that we did epilepsy surgery on. This patient has EEG electrodes implanted on their brain, so we can find the seizure exactly. So this is all the electrodes we implanted, this big grid with all these electrodes. We have about, sorry, that's my phone. That's my happy song. All right, so we have all these EEG electrodes implanted, and we found his seizure coming from just 2 electrodes. So this is a recording of all these EEG electrodes, and with all these electrodes in, the surface recording showed the seizures just coming from diffusely that area, but we didn't know exactly where. And we wanted to be able to do surgery. So this is how surgery can help us find the pinpoint. All these electrodes, you see one electrode is making the seizure down here. Totally cool. That with all that activity, we found just one spot showing us the seizures coming from. All these electrodes, everything's quiet with just this one spot making seizures. That's how surgery can be so helpful. So we go in and we treat that area, and then the patient's seizure free. So pretty cool. All right, let's see. Maybe I'll stop there. I mean, I could talk forever, but let's stop there and see if there's any questions. Because the stuff I have is just about treatment. But let's stop there and take questions then. Any questions about anything?
You were talking about the ESES.
Yeah.
And you were saying that a certain time of while they're asleep, can you see something like specific times of the night? In the sleep patterns, like specific times more activity?
Yeah, so, I mean, it's interesting. So we do see more activity on EEGs during certain times of night. So the most active time is falling asleep and waking up. That's when the brain's most fragile. It's very fragile for the brain to fall asleep and wake up. That's when most kids have their seizures. That specific ESES occurs during slow wave sleep. But the kids don't do anything. They're just lying there completely happy. But as far as normal activity, when patients have epilepsy, most of the time the activity is falling asleep and waking up. That's when the EEG is most active, and that's when they're most likely to have seizures. It's just a fragile time. The brain, it's hard for the brain to fall asleep and wake up. That's when we see the most seizures, and that's when we see the most activity on EEG. Yeah?
Can you tell, you know how people say they have an aura, or like a parent feels like they know when their kids
Mhm.
have a seizure? Do you see that like on the
Mhm.
EEG where you're like, oh, there's a little, like,
Yep.
what does that look like?
Yeah, so it's a good question. So there's two different types of things. So we used to think that all auras were focal seizures. And because when we put those electrodes on the brain, you actually see a little seizure. And we can record it. The patient says, I'm having my aura, and then we look at the brain and we see a little focal seizure. It looks very similar to this. So how this just starts with one little electrode, like when we do these electrodes, we put electrodes on the brain at the same time, there's nothing on the surface EEG. So the patient would say, I'm having an aura, and the surface EEG is completely normal. And that's when people say, well, you're just saying you're making it up, like you're not really having a seizure. But that's not true. You can't say that to patients, because if we have electrodes on the brain, we see this little seizure. This seizure with just one or two electrodes would never make it to a surface EEG. You'd never see it. So the auras are really just little seizures. But then what we also find in some patients who have generalized seizures, you can have a myoclonic seizure, which most myoclonic seizures are just a quick twitch of the upper extremities. Some patients have a myoclonic seizure that's so subtle, they just feel it in their body like an electric shock, and you don't see anything on the outside. And sometimes they have a few of those before they have the myoclonic seizure. So some patients can have what we would think of as an aura that's actually a generalized seizure as well, because they get those little subtle myoclonus, and then some of the little kids just go to their parents and just like hug them because they know something's coming, even though we don't. And so those you can see on EEG as well. So most auras you can see on EEG if you put the electrodes in the right place. But we don't often see them on surface. I've had a couple of patients where they've had EEG monitoring, and the doctors have told them it's normal, and they stop taking their meds, and then they go into status, because they really did have seizures. It was just deep, and they weren't looking in the right place. Scary, right? Don't do that. Don't stop your medicine if someone tells you you don't have seizures. Yeah?
For photosensitivity epilepsy,
Mm-hmm.
is it kind of rare to see where it's time locked to each flash when you're doing EEG?
Yeah, so it's different in different patients. So for photic sensitive EEG, sometimes we see it with every flash, sometimes we see it with just certain frequencies, sometimes we see it at the beginning of the flash, sometimes we see it at the end of the flash. So every patient's kind of unique in when they're photic sensitive. But what we try to do is let the patient know what we saw so they know what to avoid.
And is it unique? I know for my EEG, I literally, with the flash for each one.
Yeah, everyone.
You're not there, you're getting closer, like you could tell, and it correlated.
Mm-hmm.
I mean, is that kind of weird or unique?
No, it depends on what the diagnosis is, but we see that with some patients. Yeah. And do you find that you have trouble with some colors versus other colors, like out in the real world? Or does the color not matter?
Just any bright light,
Right.
even coming on and off of a microscope or setting
Mm-hmm.
off.
Yeah. Yeah, I've had some patients that tell me that the car blinkers, but if it's the orange blinker, it's not a problem. But if it's the white blinker, then it bothers. It comes on. So some cars have different colors that blink, and depending on what color the car blinker is, if they do okay. But if it's a certain color car blinker, then they have problems. Depending on different cars have their blinkers are different. I never paid as much attention to it, but depending on the make of the car, they have different colors of the blinkers. Like if you're behind a car and the blinker on, some people can't look at it because of the color of the blinkers. We only use white lights in our lab, but some people are very sensitive to different colors based on what's going on out in the world. Yeah, we had when Incredibles 2 came out. I don't know if anyone saw Incredibles 2. I haven't seen it. There's flashing lights in that, and the epilepsy community got really kind of up in arms because there was no warning on it, and we protested, and eventually they put a warning on it. There was, back when I was a resident, I trained back in the mid-90s, and there was a movie in Japan that had flashing lights. Now, Japan didn't have a lot of different TV options, and there was a kids show that was on. Most everybody in Japan was watching it because there weren't a lot of options. It had flashing lights, and they had hundreds of kids have seizures that morning. And the doctor I was working with was one of the leading epileptologists in the country, and he was asked to give a comment about it. And they calculated how many patients should have photic sensitive epilepsy based on the population of Japan, and pretty much everybody in the country who should have photic sensitive epilepsy sees that day, because they were all exposed to this one cartoon that had flashing lights. So it's like, well, it's not outside what you would expect for the population of Japan. They just all happen to be exposed to the right frequency of flashing lights at the same time. Crazy, right? That's what happens. You gotta be careful with those flashing lights. Yeah.
Sorry, one more question. And so the one where you kind of did the internal, like,
Mhm.
you know, like, you only do that for like a surgery candidate? I mean, I would imagine that.
Yeah, so that was a patient that had, they had enough focality to their epilepsy that we could tell that the seizures were likely coming from that region of the brain. We just needed to narrow it down a little farther. So usually for surgery, you have to at least be able to identify, usually I like to say front or back, left or right. Like I can do left front, left back, right front, right back.
So how do you do that, actually? How do you?
So there's lots of ways we can do it. This was an older film. For this patient, we actually did a crane. We actually opened up the brain and put electrodes right on the brain. We close everything back, we plug it in, and then we go back and open it back up and take the brain out. We now are doing more of what we call stereo EEG, where we just put little electrodes in, which is a little less precise because I don't have as much brain coverage, but more patient friendly.
Yeah, they're still open. Yeah.
Well, I know, but I mean, I've been doing this for 25 years, and it actually works really well. And the complications are actually really low and the brain doesn't feel pain. So the only pain comes from cutting the bone and the skin, which is actually not that bad. Most kids get pain, stronger pain medicine just the first 24 hours. But honestly, the little kids are the best because they don't know they're supposed to be in pain, so they're not. So they're up like running around the next day. I've had kids who are eating cheeseburgers the next morning. You know, they're like, they do really well. So it's not as bad as you'd think. And to stop seizures, which are like miserable, it actually does pretty good. So the more coverage I can get, I actually like doing the invasive because I get more coverage. Stereo is what we're doing now, which most people like better because it's minimally invasive, but you don't have as good of coverage. So you've got all these little individual electrodes, so you're watching the seizure kind of jump around and kind of, I don't want to say guessing, but kind of educationally guessing how it's traveling. Whereas when you put the grids in, you look at it, you see everything. You actually see where it's going. So, I think both have their place. And if you kind of have an idea, like if you have a malformation that you already know is likely the target, then stereo probably gives you enough. But yeah, you usually have to have some focality so that you have an idea of where the seizures are coming from.
Would it be useful if lots of people did that, or is it only really useful, like you were saying, in surgery if you're trying to identify, but it's something like Dravet, a generalized seizure disorder?
Yeah, generalized is with generalized seizures, the place where we think generalized seizures is most useful is, as we talked earlier, with the thalamus. So we think the thalamus is the main relay center. So if we can really do something with stimulating the thalamus, we can probably lessen generalized seizures. I think the interesting thing about Dravet's is a lot of Dravet's patients have focal seizures. So if you're having predominantly focal seizures, that may be something, we used to think if you had a genetic disorder that you weren't a surgical candidate, but we don't think that anymore. So we have lots of patients who have focal seizures and a genetic disease who we still do epilepsy surgery on. So if the seizures are coming from one spot and they're very clearly coming from that spot, even if you have a genetic disorder, we'll still offer surgery. But for generalized seizures, it's a little more difficult. So that's where something like neuromodulation would come into effect, something like stimulating the deep structure so that we can stop the generalized seizures. But Dravet's is more mixed, so it depends on which is the most problematic. So if the generalized are more problematic, then surgery is probably not going to be a great option, at least right now. Yeah, it's hard. Tough kids, yeah.
If you had a patient who had drug-resistant epilepsy, and they started their second combo therapy and had a 72-hour EEG that came back normal.
I have lots of, yeah, sorry, go ahead.
And not showing seizures, would you, and has a history of undetected absence seizures, how soon do you think a repeat EEG should be done if the EEG came back normal? Like, how long would you?
Do they lower meds to induce seizures?
No.
That's what I would do. So you have to record, so this is the way I practice medicine. So, I start with a routine EEG when there's new onset seizures. Once I have a drug-resistant patient, if someone's failed 2 drugs and they're still having seizures, I record seizures. Because I don't know what I'm treating, right? I have the information from the family, what they're seeing. I may have videos that I'm looking at, but until I record them on EEG, I don't know what I'm treating. So I give you an example. I had a patient that came to me who had been seen at 3 other centers, very good centers, and the description of her seizures where it's a teenager, and she would be sitting at her computer typing, and she would stop typing, her head would deviate to one side, and if she was standing up, she would actually turn in a circle. And then she would have what looked like a convulsive seizure. Everybody who saw her thought those were focal seizures, which I can't argue with because she had this pause, she had a head turn, she had eye deviation. We brought her in for video EEG, we lowered her meds, captured her EEG. Those were generalized seizures. She had like an absence type seizure. She had these short absence seizures at the beginning before the generalized seizure. I put her on a generalized medication, she's been seizure free ever since. So she didn't have drug resistant epilepsy, she was being treated for the wrong epilepsy. because they were treating her with focal medication when she had generalized seizures. But the story sounded focal. I mean, everyone who heard it, even when I heard it, I thought it sounded focal. But she was failing, she was otherwise a completely normal, and she had no problems, but she just was failing all these drugs, and it just sounded so odd. She had had a bunch of EEGs, they were all normal. There was nothing abnormal on her EEG. So you don't, and we all do that. I mean, you hear a story, oh, this sound, and I had another kiddo, I had a lovely kiddo I took care of when I lived in Pittsburgh, who had a neonatal stroke and had intractable epilepsy, and was finally seizure free, and then started having eye fluttering. I kept adding med after med after med, and then finally brought him in. It was behavioral. I mean, who knew? And we did an EEG, it weren't seizures. And so we just told him, stop doing that. I mean, you know, and so it turned out what we were treating wasn't even, I mean, that happens sometimes, you know, kids. So you need to record the seizures. You need to bring them in. You need to bring them in, lower the medication, and capture the events to make sure they're truly absence. Maybe they're focal. Maybe they are absence and they're truly intractable, and you need to think about, you know, diet therapy or some other option. But once you're drug resistant, you have to record the seizures. You just have to record seizures, because how do we know what we're treating?
So, well, they've been recorded 3 times, and the seizures were captured.
The same ones they're having now?
No, this is for my son.
Yeah.
And so he's had 3 EEGs where they've captured the seizures, and now he's on the 2nd combo therapy, and they waited for the gold dose and did the EEG, 72 hours, okay, it came back normal, let's not do another EEG for a year. And I'm like, what?
No, I wouldn't do that. And
Yeah,
and
I don't think that
the seizures he's having now are the same that he was having the last time they were recorded?
we actually haven't seen seizures since July, but he has a history of undetected seizures.
Oh.
Like either
Oh, I get it.
really small, really short, you know.
Yeah, So in that case, if you've had seizures recorded and they know for sure they know what they're treating, and you think he's seizure free,
yeah.
then I would do 3 months.
Uh-huh.
And if that's still normal, then I do 6 months.
Okay.
So it's 2 different things. So I misunderstood. So if you've already had seizures recorded and you have a good diagnosis and you think he's seizure free, and you just want to make sure you're not missing small or hard to diagnose or subclinical seizures, once I finally get someone seizure free, I do the next one in 3 months. And if that's still clean, then I do 6 months. And if that's still clean, I maybe would do 1 more 6 months and then maybe a year.
Okay.
That's the way I would do it for that.
Okay.
Yeah.
Okay.
Once you've had them recorded. Sorry, I misunderstood. Yeah. But if you've never had them recorded, you have to get them recorded.
That sits with me better than what I was told. I was like,
No, I'm really cautious about kids who have had a history of hard to detect or subclinical seizures.
yeah, I mean, how can you just go a year and
No, not in a
possibly
child.
have them?
I mean, if it was like someone your age or my age, then I wouldn't care. But kids are still developing. You got to protect that brain,
Yeah.
and subclinical seizures are going to impact learning.
Okay.
So I wouldn't wait that long.
Thanks.
Yeah, I mean maybe 6 months, but I would do 3 months. If someone said 6 months, I would be like, okay, well that's probably
Yeah,
okay.
That's,
But
it's better with me.
I would do 3 months if it were me. I mean, it's just an EEG. It's not like we're putting them to
Yeah.
sleep.
Yeah.
I mean,
Okay.
you know, if you had to put someone to sleep, like anesthesia, I'd maybe do. If it's an MRI, you know, that's a different story. But it's just an EEG, like we're just slapping electrodes on the head.
Yeah. Okay. Very
It's
good.
like a nothing,
Thank you.
right? And you can get them everywhere now. Like now they have all these companies that come to your house and do them, right? I mean, this is like a no-brainer. All right, yeah. Sorry. Any questions? I'm probably late. They're going to come yell at me. Because you know, I could talk all day about epilepsy. I mean, you guys don't know me, but I could talk all day about epilepsy. I could. Okay.
Then how
Yes.
would
Oh, sorry. Yes.
So then how would you treat?
My friendly family.
Yes. So then how do you treat an intractable, complex partial, and generalized epilepsy with ESES?
Well, goodness. So if you have focal and generalized, you have to use broad spectrum. So you have to stay away from the pure focal and the pure generalized drugs. So we have a number of broad spectrum medications that you have to use. Usually we treat Oh my gosh, who's looking for me? Maybe Chris. Give me just 1 second to see who this is. Hello? Yes. Oh, okay. Sorry, I was giving a lecture. Sorry, no, it's okay. Tell me, who is it? Oh, okay. Is it something I have to answer tonight? Okay. ready? Okay. Yeah, it's not uni, it's ready. Okay. All right. Yeah. But lots of bedtime. Okay, no worries. Okay, no worries. Thank you. All right. Sorry, it's my nurse. Okay, no worries. Okay, sorry, I got sick kids all over the place. All right, so you have to use broad spectrum medications that treat both focal and generalized, and not the pure focal or the pure generalized. The way we treat, so there's different types of ESES. There's pure ESES in patients with classic Landau-Kleffner, and then there's people who have epilepsy that have sleep-activated EEGs that also fit the criteria for ESES. That's a different category. So when I treat that, so usually we try the high-dose Valium first. I was one who actually was the first person ever to do high-dose Valium. I did it when I was a fellow with one of my mentors. We were the first ones to write the paper about it. So I have probably the most experience since I was the first one to use it. So often I'll try that just because it sometimes works. Although people don't always try that. If it doesn't work, the first dose is probably not going to work. Other than that, we often try steroids. Steroids can be effective in settling down that EEG. I'm working with a colleague of mine at Children's, and we're using a new type of steroid, which we've had really amazing success with. We're just getting ready to publish our paper on that. So I can talk to you about a little offline because I don't want it on camera. So I can talk to you about that. And then, so you have to settle the ESES down, you usually have to use either the Valium or steroids or IVIG. You usually need some immunotherapy. Other drugs don't usually fix the ESES. The only drugs that have shown to decrease spikes, so when we think about treating EEG, seizure medications treat seizures by stopping the spread of the seizure activity, but they don't usually touch the EEG, with the exception of infantile spasms. The medicines we use to treat infantile spasms settle down the EEG, but we usually use steroids for that. So traditional seizure medicines, like your Tegratols and your Lamictals and your whatever, they don't fix the EEG. The only exception is valproic acid or Depakote and levetiracetam or Keppra. Those two drugs can normalize your EEG. So those may have some impact on the sleep-activated EEG or the ESES-looking EEG in patients with epilepsy. No other seizure drugs can do that. Those are the only two. So those sometimes are tried in patients who have sleep-activated EEGs because they're what we call spike suppressors. They're the only two that are. But otherwise, we usually use either benzos or steroids or IVIG, some immunotherapy, to try to settle that EEG down. Has any of those things been tried?
We've tried Keppra, and she strangled her.
Yeah, Kepra's.
Yeah.
Got it.
We've gone through the gamut. We've honestly gone through the gamut.
Yeah.
We've gone through everything, including Depakote, including pretty much everything.
Let me